Hi, my name is Robert Olson. Welcome to what I hope will be an informative discussion on treating dental crowding using early expansion as an alternative to extraction treatment. First of all, I would like to begin by introducing Nicole. Nicole is 7 years old and is very typical of the type of young patient that is routinely seen by the orthodontist today. As you can see, Nicole is extremely crowded. When we see young patients with this much crowding, usually the first thing we think about doing is extracting the primary teeth to make room for the crowded lateral incisor teeth. Or the other thing that we might do is choose to wait on making any decision on removing teeth and examine Nicole, say, in 6 months. However, waiting is something we most likely would not consider with this much crowding. These choices, extracting primary teeth or waiting and continuing to observe for a while, have pretty much been the scope of what we believe we can do at this age to deal with severe crowding. However, analyzing the records of many untreated young patients over the course of their dental development revealed to me that many children with severely crowded teeth improved with time to the point that with some early orthodontic intervention, the severity of their dental crowding could be substantially reduced without the extraction of teeth. This is Nicole 5 years later following an initial phase of early expansion treatment. Her permanent teeth have erupted and she is now ready to begin her second finishing phase of treatment. The dental arches do not appear to be overly expanded and the incisor teeth appear to be in good position, not excessively proclined. If this was the first time we saw Nicole, we would not consider the crowding of her teeth as a chief concern, and extracting teeth would certainly not be our immediate treatment recommendation. This is, of course, the same patient on whom many of us would have recommended extracting teeth 5 years earlier. Nicole is an example of how extremely crowded young patients can favorably improve with early treatment, preventing the need to extract teeth. When I started doing early expansion treatment, it was considered very much unconventional and was surrounded with a lot of controversy and skepticism. This might not be so much the case today. At that time, extraction treatment had a deep-seated influence in our profession, and expansion treatment was used in very limited circumstances. Many of the concerns with dental expansion, in the past and today, are with tooth-supported expansion in older children done after the eruption of the permanent teeth. Some of these concerns, of course, have been mitigated with the use of tissue-supported as opposed to tooth-supported appliances. Early expansion, however, is expansion that is done in the early mixed dentition before the eruption of the permanent cuspid and premolar teeth, so the effects on the dentition are not the same as expansion done after these teeth have erupted. Cuspid teeth and premolar teeth erupt naturally unsubjected to direct orthodontic forces. As a result, the stability of expansion and the effects of expansion on the periodontium are very different. Early rapid palatal expansion treatment is generally accepted within our profession as an effective method for correcting insufficient transverse dental arch dimension. Early expansion for severely constricted dental arches is routinely recommended. However, rapid palatal expansion is not routinely recommended to correct dental crowding in situations where a dental crossbite relationship or severely constricted dental arch is not present. Like in Nicole's case, crowded incisor teeth are often the main reason very young patients are referred to the orthodontist. Crowding is a concern when the permanent teeth first erupt. Traditionally, the treatment recommendation for young children with crowding has been to initiate serial extraction treatment or to do nothing and wait and observe the patient for a period of time before making any decision on extraction of teeth. This early-on crowding, seen in these young, sometimes 6- and 7-year-old children who are being referred to the orthodontist for treatment, I believe is largely a result of insufficient inner canine dimension and the factors that contribute to reducing the inner canine dimension. If we are going to provide meaningful treatment outside of simply extracting primary teeth, things that affect the crowding of the permanent dentition need to be modified at an early age well before the eruption of the permanent mandibular cuspid teeth, which establishes the dental arch dimensions that affect and sometimes constrain our treatment decisions. Effective expansion needs to be started 18 to 24 months prior to when the permanent mandibular cuspid teeth are expected to erupt. This means that early expansion will need to be started as early as 7 to 8 years of age. I was in the private practice of orthodontics in St. Louis, Missouri for 42 years. I also was affiliated with the Washington University Orthodontic Department until its closure in 1991. I am presently an adjunct professor of orthodontics at A.T. Still University, Missouri School of Dentistry and Oral Health. This is a presentation that I put together to describe how I used early expansion treatment to treat what I would consider severe to moderately severe dental crowding without extracting teeth. This is a very proactive treatment protocol that requires starting orthodontic treatment at a very young age. Because it is necessary to start treatment at a young age, many orthodontists might feel uncomfortable doing this type of treatment. Opinions on early treatment differ within our profession. I am not sure what is being taught in orthodontic programs today, but in the past, orthodontic residents were not routinely seeing 7- and 8-year-old children for orthodontic treatment. Historically, there have been legitimate controversies surrounding the value of early orthodontic treatment, which contributes to our reluctance to treat younger patients. We do not want to put patients through unnecessary early treatment if that treatment is not significantly benefiting the patient and improving the treatment outcome. Certainly, averting extraction of permanent teeth is a substantial benefit that is a good thing for any patient, and I feel can be effectively achieved with early treatment in the proper circumstances. Before discussing treatment, however, I would like to consider some of my observations regarding dental crowding, as well as some of the principal tenets regarding dental development, and my rationale for early expansion treatment based on these considerations. I will also discuss what the treatment objectives for early treatment should be, and the clinical procedures and appliances used. I will then review some treated patients that I feel represent the type of patients that can be effectively treated with early expansion. One of the big uncertainties in all orthodontic treatment is knowing the limits of the denture alveolar base. Today, with cone beam tomography, we are gaining a better understanding of the effects of tooth movement on the alveolar bone. Treating crowding without removing teeth requires increasing the dental arch dimensions. This means the dental arch will need to be widened and the incisor teeth will need to be advanced or proclined. The question is, how much is okay? What are the anterior and lateral limits of the denture base? Is harmful bone loss occurring? Traditionally, orthodontic treatment objectives were to not expand inner canine dimension or move mandibular incisor teeth labially. Uprighting lower incisor teeth was usually the goal. However, in many orthodontic treatments, incisor teeth are advanced and the dental arch is expanded to some degree, especially with the use of preformed supraelastic arch wires. Expansion and incisor advancement routinely occurs in our orthodontic treatments. It happens in non-extraction treatment when there is no spacing, in routine leveling procedures, when intermaxillary mechanics are used, and even at times in extraction treatment. Lower incisor teeth are usually only uprighted lingually in Class 3 treatment or enclosing excessive spacing of teeth, or in extraction treatment without intermaxillary mechanics. Moreover, there is the same risk of harm to the periodontium when teeth are moved labially or lingually. Orthodontic tooth movement causes changes in alveolar bone height and cortical bone thickness. Cone beam computer tomography studies have found vertical bone loss occurs in both non-extraction and extraction treatment on both the labial and lingual surfaces of the teeth. These changes can be statistically significant, however, are not necessarily clinically significant. Alveolar bone loss, like external root resorption, is always associated with orthodontic treatment to some degree, but fortunately rarely enough to be harmful to the patient if good orthodontic principles are followed. Extracting teeth to avoid proclining incisor teeth will not prevent bone loss. Also, studies have shown that there is not a correlation between inclination of incisor teeth and bone loss, nor is proclining incisor teeth during orthodontic treatment conclusively correlated with increased gingival recession. Rationalizing extraction of permanent teeth to avoid bone loss, prevent gingival recession, or to prevent relapse is a flawed rationalization or justification. All these things can occur in both extraction treatment and non-extraction treatment. In addition, the increased risk of root resorption is most likely greater in extraction treatment, and obtaining good functional dental occlusal relationships can also be more challenging when teeth are extracted. There are definitely indications for extraction treatment and contraindications for non-extraction treatment. But if you see a young patient with significant crowding and you feel extraction treatment is undesirable, the decision must be made as to when you should best treat. Of course, there can be different options for most all orthodontic treatments. The goal of early treatment for crowding should be treatment that has definite treatment objectives, with predictable results, that is in control of the orthodontist and can be done in a reasonable treatment time, and is beneficial to the patient and prevents the need to extract permanent teeth. Treatment, of course, that is done within the parameters and standards of good orthodontic care. Today, many young patients, like the one in this slide, are referred to the orthodontist. This is something our profession has been actively promoting for many years. However, uncontroversial early treatment for these patients remains very limited. Treatments are limited to things like anterior and posterior crossbite correction, space maintenance, habit control appliances, or serial extraction procedures. Functional appliance treatments, which might be recommended for young patients, are still open to question and are appliances, with the exception of lip bumper treatment, used primarily for correcting skeletal discrepancies. Lip bumper treatment can be an effective treatment for creating space when you have dental crowding, but can require a long period of treatment time with less certainty and control of treatment outcome. The next several slides are examples of what you often see when a young 7-year-old patient is referred to the orthodontist as recommended by the AAO. This patient has blocked out upper lateral incisor teeth and a blocked out lower cuspid tooth. Here is a patient with a narrow dental arch with insufficient space for the upper and lower lateral incisor teeth. And here is another example of a young patient with blocked out lateral incisor teeth. How are these crowded patients best treated? Is serial extraction the only treatment choice? I think that most orthodontists would not disagree if a decision was made to extract primary teeth in these types of situations. However, can something be done to avoid extracting teeth? I hope to demonstrate that there is an acceptable alternative to extraction treatment for severe crowding in young patients who you feel will be better treated without removing teeth. First of all, I would like to discuss some of my observations regarding dental crowding. I want to note that crowding will refer to anterior dental crowding. Of course, the total arch length discrepancy, anterior and posterior crowding, needs to be considered when evaluating a patient and determining treatment. However, anterior crowding commonly exists when posterior crowding is not an issue. Discriminating differential diagnosis is necessary to make this determination. Posterior arch length discrepancies might be a contraindication for early expansion and must always be considered. Crowding is related to where teeth erupt. Lingual eruption of lateral incisor teeth affects dental arch development. When maxillary and mandibular lateral incisor teeth erupt lingual, the arch perimeters are reduced. If the lateral incisor teeth are not aligned early, the permanent cuspid teeth can erupt more mesial lingual, creating an even greater arch length discrepancy. Anterior crowding is primarily an intercanine dimension problem. Creating 15 or 16 millimeters of space with premolar extractions to correct 7 or 8 millimeters of incisor crowding still has a high propensity for relapse. Mandibular anterior crowding is often associated with deep overbite. Here is an example of a deep overbite with upright maxillary incisor teeth entrapping the mandibular anterior teeth and reducing the mandibular intercanine dimension. I would point out that due to the crown contours, the maxillary arch dimension, which confines and restricts the mandibular arch boundaries, is smaller when measured at the gingival margins of the teeth. This is because of the greater labiolingual thickness of teeth at the gingival margins. Thus, the deeper the overbite, the more the mandibular intercanine dimension is reduced. I would also note, because of tooth contour, if the mandibular intercanine dimension is unchanged during orthodontic treatment, the maxillary intercanine dimension needs to be constricted to maintain cuspid contact when a deep overbite is corrected. This would be true in extraction or non-extraction treatment. Likewise, to maintain cuspid occlusal contact when correcting a deep overbite, the mandibular intercanine dimension must be expanded if the maxillary cuspid teeth cannot be constricted. Anterior crowding, primarily lower crowding, is affected by interarch relationships and the sequence of dental eruption. Because the mandibular cuspid teeth erupt considerably earlier than the maxillary cuspid teeth, they emerge into a functional occlusion with opposing teeth that have a smaller intercanine dimension than their succedaneous counterpart. Of course, a narrowed maxillary arch would have an even greater effect on mandibular crowding. Mandibular growth rotation and position of lower incisor teeth, that is, interincisal angle, affects anterior crowding. The location of the fulcrum of growth rotation can affect incisor uprighting and deepening of the overbite, resulting in increased mandibular incisor crowding. This is something that Bjork described in his implant studies. Therefore, reducing the interincisal angle by proclining incisor teeth could be beneficial in the treatment of crowding. If the previous observations accurately characterize anterior dental crowding and the conditions that might contribute to its development, what are some of the normal developmental processes that occur which help increase the dental arch size as a child grows? First of all, we know an increase in intercanine width naturally occurs when the permanent incisor teeth erupt. We call this secondary spacing. The average increase is 3 millimeters in the mandibular arch and 4.5 millimeters in the maxillary arch. Removing primary cuspid teeth at the very time intercanine dimension is increasing as a part of normal development might not be the best thing to do. Enhancing the process with early expansion in the right circumstances might be a better choice. Secondly, simultaneous with secondary spacing, sutural growth is also occurring in the maxilla, which is another developmental process that can be favorably modified by the clinician. Thirdly, in normal development, the permanent incisor teeth erupt slightly labial to the arch position of the primary incisor teeth, which also increases arch length by increasing the anterior arc of the dental arch. When this normal eruption pattern does not occur, moving incisor teeth labially during early stages of eruption might be appropriate to alleviate crowding. Fourthly, studies describing rotational growth changes of the mandible suggest that uprighting mandibular incisor teeth, which creates a more obtuse interincisal angle, can lead to deepening of the overbite and increased crowding of the mandibular anterior teeth. Creating less obtuse interincisal angles to avert increasing incisor crowding requires moving incisor teeth labially. Fifth, development and growth of the alveolar bone is dependent upon the development and eruption of teeth. Early repositioning of teeth before full eruption might logically induce dental alveolar development. If commonly lingual-verted lateral incisor teeth are not repositioned early, this creates an alveolar bone deficiency labial to these teeth, which limits the proper labial root movement and affects stability. Sixth, the Iowa growth study found that after age 7, the maxillary intermolar width increases an average of approximately 3 millimeters, and the mandibular molar width increases on average approximately 2 millimeters during a child's growth years. Early expansion, again, is concordant with these normal expected growth changes that increase rather than decrease the dental arch size. And of course, leeway space can provide additional space for the permanent teeth when the deciduous molar teeth exfoliate. Recognition of the various factors that potentially contribute to crowding and the precepts of normal growth and development, which can naturally increase a growing child's dental arch length, gave rise to the following treatment objectives. 1. Treat early, 18 to 24 months prior to the eruption of the permanent mandibular cuspid teeth. The permanent cuspid teeth and premolar teeth will erupt naturally, establishing the dental arch dimensions without being expanded after eruption. 2. Expand the maxilla. This is done with a rapid palatal expansion appliance. 3. Expand the mandibular primary cuspid teeth. This is done with a W expander, or what is called a Porter appliance, or similar appliance, to allow for the alignment of the crowded incisor teeth prior to the eruption of the permanent mandibular cuspid teeth. Also, the mandibular molar teeth can be uprighted and or expanded to compensate for maxillary expansion. 4. Align the crowded incisor teeth. Properly torque lingual-verted incisor roots labially prior to the eruption of the mandibular cuspid teeth. This also prevents the reduction in intercanine dimension that can occur with the mesial lingual eruption of the mandibular cuspid teeth when the lateral incisor teeth are left lingually displaced. 5. When necessary, move the maxillary and mandibular incisor teeth labial to reduce overbite and establish a good interincisal angle. 6. Reduce deep overbite by tipping incisor teeth forward or by intruding incisor teeth with a utility arch. 7. After the incisor teeth are aligned and properly positioned, maintain arch dimensions and incisor alignment with proper retention. A lingual arch space maintainer is placed to maintain the mandibular arch length and intermolar width. The lingual arch wire also maintains beneficial leeway space. A removable retainer is placed to maintain the maxillary arch dimension and incisor position. Now I would like to discuss the clinical procedures and talk about the design and application of the appliances I prefer to use for treatment. A bonded or banded type rapid palatal expander, RPE, is used to expand the maxillary arch. Tissue-supported appliances could also be used, but I think long-term experience with early expansion using tooth-supported appliances suggests that placing implants in young patients is not necessary. I prefer the bonded RPE with occlusal coverage because it provides immediate bite opening, which allows for efficient anterior crossbite corrections and permits the clinician to place appliances on the mandibular teeth in deep bite cases without restriction. The bite opening effect of the appliance also eliminates the entrapment of the lower teeth in deep bite patients and allows the lower crowding to improve autonomously during the expansion. Also, I feel there is less buccal tipping of the primary teeth when a bonded expander is used. An 11 mm standard Hyrex expansion screw is routinely used. 2 buccal archwire tubes are placed on each side of the bonded expander, so an archwire can be placed to start aligning the incisor teeth before the expander is removed. 2 tubes are placed in sequence to better hold flexible archwires. This prevents the wires from disengaging from the buccal tubes, which commonly occurs when flexible wires span a large space. When using a bonded expander, it is important that there is sufficient root structure on the primary molar teeth so they will not become mobile or exfoliate during the expansion. Always closely examine radiographs before using an RPE appliance. Insufficient root structure on primary molar teeth is a contraindication for any early expansion. To stabilize the expansion, the RPE is not removed until 3 months after activation is stopped. The RPE is activated 1 turn every other day starting the day after placement for 2 weeks and 1 turn every day for 2 to 4 weeks thereafter, depending on the desired amount of expansion. I have found this to be a very effective and tolerable activation schedule, but the appliance can be activated in any way that you feel best. In Class 3 cases, where protraction headgear is necessary, elastic hooks are added to the appliance. When protraction headgear is used, the RPE is usually not removed for at least 6 months. Before cementing, the bonded expander is equilibrated using articulating paper, so the patient is occluding evenly on the plastic, which makes the appliance more tolerable and comfortable. This also reduces bond failures by eliminating unbalanced biting forces on the plastic that might loosen the appliance. The appliance is bonded with self-cured 2-part paste adhesive. It is very important to only etch the buccal surfaces of the teeth. Do not etch the occlusal surfaces of the teeth. When only the buccal surfaces are etched, the appliance is easily removed using an adhesive removing plier by gently inserting it along the buccal edge of the expander and firmly squeezing the plier without torquing the appliance to loosen the bond before lifting the appliance off the teeth. The mandibular teeth are expanded with a .036 W expander Porter appliance, which has a buccal archwire tube and hook and attaches to the first molar teeth. The W expander is designed so that the lingual portion of the appliance is not compressed against or too close to the lingual soft tissues to avoid irritation when activated. Also, if the anterior segment of the lingual portion of the appliance is located too low in the floor of the mouth, the lingual frenum can become severely irritated. The appliance is fully activated by manually overexpanding and recompressing to the desired dimension before cementation. The lingual extension wires of the expander are adapted to the lingual surfaces of the primary cuspid teeth and terminate with a right angle bend. The ends of the extension wires, which are bonded to the lingual surface of the primary cuspid teeth, are beveled to reduce bulk and enhance adaptation. Care should be taken not to overactivate the W expander. Once the expander is adjusted to the desired dimension, it should be seated on the teeth before cementing to make sure that the lingual portion of the appliance will not cause any soft tissue irritation. If bands cannot be placed on the permanent first molar teeth without causing tissue irritation, a screw-type appliance can be placed on the second primary molar teeth. A W expander placed on the second primary molar teeth is very inflexible and when activated cannot be compressed sufficiently to insert. When a screw-type appliance is placed on the second primary molar teeth, the appliance includes lingual wires extending distally to expand the permanent first molar teeth. The screw-type expander is inflexible and the expansion is uniform throughout the whole arch. The advantage of the W expander is that it is flexible and can be adjusted so that the primary cuspid teeth can be expanded without expanding the molar teeth. Bonding the ends of the extension wires to the primary cuspid teeth keeps the wires from submerging subgingivally or riding up over the occlusal surface of the teeth. Also, by bonding the extension wires to the primary cuspid teeth, a rigid unit is created which provides several benefits when treating in the early mixed dentition. The primary cuspid teeth become solid abutments for placing light anterior sectional arch wires for initial alignment of crowded incisor teeth. With only an anterior sectional arch wire, coil springs, intermaxillary elastics, and elastic power chain can be effectively used without the need for a heavy, continuous stabilizing arch wire for control. I would like to note that one problem with bonding the ends of the extension wires of the W expander to the primary cuspid teeth is that the bond can fail and the ends of the extension wires will occasionally need to be reattached. When sufficient expansion has been obtained to align the incisor teeth, usually 8 to 10 weeks, the maxillary and mandibular incisor teeth are bracketed, as well as the mandibular primary cuspid teeth, which also are bonded to the extension wires of the W expander. Usually an 014 nitinol sectional wire is initially used in the mandibular arch. In the maxillary arch, a continuous arch wire can be used because of the buccal tubes placed in the RPE appliance. In this patient, not all brackets were placed to allow for additional eruption of the lateral incisor teeth. The RPE appliance required additional activation. Brackets were placed on the central incisor teeth to control the enlarging midline diastema. After the RPE appliance is removed, buccal arch wire tubes are placed on the permanent first molar teeth. Once the mandibular incisor teeth are aligned sufficiently to place a rectangular arch wire, the brackets are removed from the primary cuspid teeth and the extension wires are removed from the W expander. A continuous utility arch wire is placed to torque, advance, and if necessary, intrude the incisor teeth. The lingual arch portion of the W expander is not removed in order to stabilize the molar teeth and prevent rotation and tipping that can occur when using a utility arch. I would also note that after removing the RPE appliance, molar bands can be placed if a headgear appliance is needed to improve the molar relationship. Today, with the use of temporary anchorage devices, headgear would not likely be the selected choice of treatment. A continuous utility arch wire, usually at 0.017 by 0.025 TMA, is placed to torque, advance, and if necessary, intrude the incisor teeth. Note that it is especially important when using 2x4 type appliances in the mixed dentition that the arch wire is level before engaging the incisor segment. An unlevel arch wire can create transverse discrepancies which can be difficult to correct. When treatment objectives have been achieved, appliances are removed and a maxillary removable retainer and mandibular space-maintaining lingual arch wire are placed. The maxillary Hawley appliance is designed so the remaining primary teeth can exfoliate and the permanent teeth can erupt without interference while wearing the retainer. Adams clasps are used on the permanent first molar teeth, so exfoliation of the primary molar teeth will not affect retention of the appliance, and the labial bow is simplified to allow for eruption of the permanent cuspid teeth without interference. Before showing examples of treated patients, I would like to discuss diagnosis and the context in which I view some of the traditional cephalometric parameters we use to evaluate our patients. Two of the most important things to me when assessing whether or not to extract teeth are 1, the patient's facial continence, and 2, the position of the upper incisor teeth. If the upper incisor teeth are well related to the upper face and a patient has a good unstrained facial continence, I believe extraction of teeth increases the risk of unfavorable aesthetic changes. Patients who have crowded dental arches and who have good facial features with upper incisor teeth in good position, or in cases where upper incisor teeth are too upright, are the types of patients that can benefit from early expansion treatment. Since early expansion is done before the eruption of permanent cuspid teeth and premolar teeth, the most significant dental arch modification to increase dental arch length after the permanent teeth have erupted is the advancement of the lower incisor teeth. Proclining incisor teeth commonly occurs during orthodontic treatment. In many orthodontic treatments, incisor teeth are necessarily advanced a few millimeters, which is routinely considered acceptable. I would contend that in frequent instances where the lateral incisor teeth are positioned lingually, moving these teeth labially 3 or 4 millimeters is not unusual. This is certainly the case when an upper lateral incisor tooth in complete lingual crossbite is moved out of crossbite. Extracting premolar teeth to correct crowding is done to retract the cuspid teeth into the premolar space, which is a wider part of the dental arch. In Class 1 occlusion, the upper and lower cuspid teeth will need to be retracted in equal amount to maintain proper occlusion, and in Class 2 occlusion, the upper cuspid teeth will need to be retracted even more. This means that patients with well-positioned upper incisor teeth before treatment might have these teeth retracted to a more unfavorable position. When the upper incisor teeth are well related to the face before treatment and premolar teeth are extracted, the risk of unfavorable aesthetic facial changes increases. Retracting teeth that are well positioned before treatment can result in a dentition appearing too small for the face or too dorsal in the oral orifice with large buccal corridors, thinning or tethering of the lips, an obtuse nasolabial angle, and concave lower facial profile. These are features which are today generally considered less desirable in our profession. If proclining incisor teeth is the most significant change required after early expansion to increase dental arch size, is it a better option than extracting 4 premolar teeth? That seems to be the fundamental choice. The question is, how much advancement is acceptable? This is a question that needs more research to quantify. Cephalometric means have been established for what are considered good positions for incisor teeth. In the past, these means became specific treatment goals and in some cases the rationalization for extraction of teeth for orthodontic treatment. It was accepted that these cephalometric means were stable tooth positions. That, of course, was not the case. From the point of view of facial aesthetics, there is a large variation in the positioning of the incisor teeth. For example, the lower incisor to mandibular plane angle, which averages about 90 degrees, has a standard deviation of 5 degrees, and within 2 standard deviations, in 95% of the population of normals, a variation of plus or minus 10 degrees. Similar results are found in our other cephalometric means that we use for diagnosis and treatment planning. For example, lower incisor to point A Pagonian line for 95% of the population normals has a total variation of 8 millimeters. These are means established for subjects with desirable faces or good occlusions. Patients with skeletal variations have even greater variation in the position of the incisor teeth. Even though there is variation in incisor tooth position, that does not mean there is a comparable variation in the limits of incisor tooth movement. A lower incisor tooth that starts out at 95 degrees might reasonably be inclined to 98 degrees without much concern, but an incisor tooth that starts out at 90 degrees and is tipped to 98 degrees would create more anxiety as to exceeding the limits of good treatment. I will be describing the cephalometric changes that occurred during the treatments I will be presenting so that you can see what kind of changes can be expected with early expansion treatment. I primarily focus on the changes in the incisor teeth. Inclining the incisor teeth increases the dental arch length. Mathematical models show that the amount of arch length increase varies depending on the shape of a patient's arch form and on the type of tooth movement that occurs. either controlled or uncontrolled tipping of the incisor. With controlled tipping, the tooth's root apex remains in the same position, whereas in uncontrolled tipping, the root apex moves lingually as the crown tips labially. These models show that 1 millimeter of proclination without modifying inner canine width results in an incisal angulation average increase of 2.63 degrees for controlled tipping and an average of 3.33 degrees for uncontrolled tipping. 1 millimeter proclination was found to increase arch length by 1.5 millimeters to 2.06 millimeters depending on arch form. I believe tipping a lower incisor tooth 2 or 3 millimeters is routinely done in many orthodontic treatments. If this is true, increasing the IMPA 6 to 10 degrees is certainly a viable alternative to extracting 4 premolar teeth. Cone beam tomography studies hopefully will give more clarity to the effects of our treatment on the periodontium and what the limitations of our treatments might be. Even though we do not have precise quantitative established parameters, the fact that we understand there are limitations to our treatments has allowed us for many years to successfully treat orthodontic patients without clinically significant detrimental consequences. Bone loss associated with orthodontic tooth movement is quite variable for individual patients. Advancing a lower incisor tooth 4 millimeters will not necessarily cause the same amount of bone loss in every patient. The amount of bone loss is affected by the initial alveolar bone height and cortical plate thickness before starting orthodontic treatment. The following treatments I selected represent an array of patients and the typical progression of two-phase type treatments. Early treatment requires ongoing reevaluation as the patient develops. I will explain my reasoning for choosing not to extract teeth on these patients, but certainly in many of these patients, extraction treatment was equally contemplated. This is a composite of the facial profiles of patients presented in this presentation. All these patients had significant dental crowding and were treated without removing teeth. These profiles are by no means full or excessively convex. Lip continence is good and not strained. I think these patients definitely benefited from not having teeth extracted. As I mentioned, I will be showing patients that can be effectively treated with early expansion. I believe orthodontic problems can be characterized on a spectrum or continuum, where at the ends the problems are well defined or more black and white, where we all pretty much agree on treatment, but as we move to the middle of the spectrum, the gray area, there is less clarity and more personal judgment comes into play in our treatment decisions. Our professional judgments are, of course, influenced by different things. The first several patients that I present are what I would consider more straightforward examples of Class 1 crowding and would be more in the middle of the spectrum or gray area. These are patients who some might not want to extract teeth, but choose to manage by simply waiting for the eruption of the permanent teeth, possibly along with some adjunctive space maintenance before starting treatment. Also, patients with anterior and/or posterior crossbites will demonstrate how early treatment for crossbite correction can be more comprehensive and address a patient's crowding as well when extraction of teeth is undesirable. Less straightforward examples of early treatment include patients with severe crowding who require Class 2 correction, and patients with open bites, and patients who have advanced gingival recession prior to treatment that might be considered poor candidates for expansion treatment. This is Jessica. Jessica is almost 9 years old. Her occlusion is Class 1 with narrow dental arches and crowded lower incisor teeth and insufficient space for the eruption of the upper lateral incisor teeth. Also noteworthy, Jessica's dental development is significantly delayed, so dentally Jessica is more like a 7-year-old than a 9-year-old. Jessica's Panorex confirms her delayed dental development. The maxillary lateral incisor teeth are unerupted, and the root formation and resorption patterns overall appear behind schedule. Jessica has a somewhat recessive lower facial profile with an obtuse nasolabial angle. A and B angle is 7 degrees. The incisor teeth are upright. The upper incisor to SN is 99 degrees, and the IMPA is 89.5 degrees. I definitely did not want to extract teeth on Jessica. Jessica is the type of patient I would consider more towards the middle of the treatment spectrum I previously described. Some might choose to simply wait and treat Jessica with the eruption of the permanent teeth. However, early treatment in this type of patient is very effective and can favorably enhance dental development, avoiding some of the potential adverse consequences of waiting several years, like the lateral incisor teeth erupting lingually, possibly into crossbite, or the lower cuspid teeth erupting mesiolingually, increasing the lower crowding. Also, when a patient's dental development is delayed, improvements from early treatment are important to patients who do not want to wait years to start orthodontic treatment, as was the case with Jessica. Jessica's delayed development was a factor in deliberating early treatment. This is Jessica after the completion of her early expansion phase of treatment. Because of Jessica's delayed dental eruption, after expansion was completed and sufficient space was created for the maxillary lateral incisor teeth, her upper anterior appliances were removed to wait for the lateral incisor teeth to erupt. This is something that I will do if it appears eruption is going to take some time. I do not like keeping patients in fixed appliances while waiting on teeth to erupt. When the maxillary lateral incisor teeth are severely crowded, expanding before their eruption will prevent their lingual displacement and allow them to erupt into their normal alignment. For this reason, expanding before their eruption is beneficial, but can lengthen the time patients are in appliances while waiting on their eruption. Usually, at this stage of treatment, only 4 brackets need to be removed. I do not remove the molar brackets, so it is very easy to replace the anterior brackets when the lateral incisor teeth are sufficiently erupted to complete aligning the incisor teeth. This is Jessica 4 years after the completion of her Phase 1 treatment. At age 13 years, 8 months, the upper right second deciduous molar tooth was extracted in order to move forward with Phase 2 treatment. There is sufficient space for the permanent teeth without having to orthodontically expand the permanent cuspid teeth and premolar teeth. The dental arches are well related and the anterior teeth are not excessively proclined. There are no signs of visible root resorption or root dilaceration from the early alignment of the incisor teeth. This is consistently true when aligning crowded incisor teeth at an early age. That will be demonstrated in all the patients that I show in this presentation. Early movement of incisor teeth is routinely done in orthodontic treatment without detrimental effects on the teeth. The second phase of treatment took 11 months. At the completion of treatment, a lower fixed retainer is routinely placed. Normally, I use a fixed retainer that is bonded only on the cuspid teeth. In this patient, a wire was placed that was bonded on each tooth. The type of fixed retainer used is determined by the requirements for good retention. I believe all patients who initially have anterior crowding or incisor irregularity will require permanent retention. This is true for non-extraction treatment as well as extraction treatment. Placing upper fixed retainers is more challenging but can be beneficial in controlling isolated tooth relapse. For example, lateral incisor teeth, which were initially lingually displaced, can be difficult to retain with removable retainers. This is Jessica 4 years out of treatment. At the end of treatment, Jessica's IMPA increased from 89.5 degrees to 93 degrees, and the upper incisor to SN favorably increased from 99 degrees to 103.5 degrees. A and B improved from 7 degrees to 4.5 degrees. This is a summary of the significant cephalometric changes at the completion of treatment. The Class II skeletal relationship due to a recessive mandible improved. SNB improved from 75 degrees to 78 degrees, and a high mandibular plane angle of 40 degrees improved to 37.5 degrees. The A and B angle improved from 7.5 degrees to 4.5 degrees. The normal maxilla remained unchanged, with improvement in the upper incisor position. The upper incisor to NA improved from 16 degrees to 20 degrees, and the upper incisor to SN improved from 99 degrees to 103.5 degrees. The lower incisor position remained within acceptable cephalometric parameters. The IMPA went from 89.5 degrees to 92 degrees. This is Greg, who is similar to Jessica. I would not want to extract teeth on this patient. The occlusion is class 1 with a deep overbite, possibly class 2 tendency, with an almost completely blocked out lower incisor tooth and insufficient space for the upper lateral incisor teeth. The anterior teeth are too upright and the lower midline is deviated several millimeters to the patient's right side. At the completion of phase 1 expansion, sufficient space for the eruption of the permanent teeth has been created and the overbite has been improved by proclining the incisor teeth. There appears to be slightly more of a class 2 tendency. This sometimes occurs after expansion. 4 years after the completion of phase 1, Greg is ready for phase 2 treatment. The occlusion is very good and the lower midline is centered. I like to wait for the eruption of the second molar teeth before beginning phase 2 treatment. This is important so fixed appliance treatment time will not be extended. Also, treatment objectives like leveling and bite opening are more easily accomplished when the second molar teeth are present. The lower lingual arch placed after phase 1 treatment was removed early, so some slight lower incisor irregularity developed. The lingual arch is generally not removed until phase 2 treatment is started. However, occasionally molar bands can obstruct the eruption of the second molar teeth, so the lingual arch appliance will need to be removed to allow for their unimpeded eruption. Also, there can be instances when erupting cuspid teeth or premolar teeth are obstructed by the lingual arch wire. If that occurs, I generally remove the lingual arch wire and try to adjust it or remake it. The lingual arch wire is initially designed so that it generally will not interfere with the eruption of the permanent teeth. After phase 1 treatment, the root structure of the incisor teeth appears normal with no adverse effects from early orthodontic alignment. I would note that today with Invisalign treatment, some orthodontists might choose to use Invisalign for phase 2 treatment. I think you will see that many of these patients have very good results after the initial phase of treatment and require uncomplicated, straightforward treatment to complete the second phase. Occasionally, there are patients who choose not even to have a second phase of treatment. If early expansion treatment, which usually can be completed in 12 to 15 months, eliminates the need to extract teeth and can be finished with Invisalign treatment, removing the need to place fixed orthodontic appliances for the second phase of treatment, it becomes an attractive alternative to a 2.5-year extraction treatment as a teenager. This is Lauren. I wanted to include Lauren because I photographed some of her office visits to illustrate the appliances used, which were described previously, and the progression of a typical phase 1 treatment. Lauren is basically class 1 crowded, with the lower midline deviated to her left side. On Lauren's third visit after placing the expansion appliances, brackets were placed on the anterior teeth. Brackets are not placed until most of the expansion is completed and space is present to align the crowded incisor teeth. Bonding the extension wires of the lower W expander to the primary cuspid teeth provides solid abutments for placing a lower sectional .014 nitinol wire. The wire is cinched distal to the cuspid brackets to prevent flaring of the incisor teeth. Because there is space distal to the lower right lateral incisor tooth, a very lightly activated open coil spring has been placed to start the lower midline correction and also to start opening space for the blocked out left lateral incisor tooth. The RPE appliance is usually removed 3 months after completion of activating the appliance. Brackets are placed on the first molar teeth to continue aligning the maxillary anterior teeth. The mandibular teeth are still being aligned using only a sectional arch wire. Several months later, when the incisor teeth are sufficiently aligned, the extension wires are removed from the W expander and a lower 17 by 25 TMA utility arch wire is placed. Brackets are also removed from the lower primary cuspid teeth. The lingual arch wire portion of the W expander is retained to maintain any molar expansion and provide molar control while using the utility arch wire. I would note that a utility arch wire is not always necessary. Sometimes the lower incisor teeth can be adequately aligned using a sectional arch wire. If a sectional wire is continued, the brackets on the primary cuspid teeth and the extension wires on the W expander would not be removed. This is the completion of Lauren's first phase of treatment. Lauren has a well-balanced facial profile. This is Lauren before starting phase 2 treatment. Things look very good. Again, Invisalign could be a treatment option rather than fixed appliances. This is Lauren's completed treatment. This is Molly. Molly is 7.5 years old. Her maxilla is constricted with a complete unilateral crossbite on the left side, causing a significant functional shift of the mandible to the left. Subsequent to the functional shift, there is a class 2 occlusion on the left side and a canted transverse occlusal plane. Both arches are moderately to severely crowded. Because of the presence of the posterior crossbite, rapid palatal expansion would routinely be recommended for this type of patient. When early palatal expansion is necessitated for crossbite correction, it also can be an excellent opportunity to be more far-reaching and address crowding as well if it is an issue. If a patient requires early treatment, it will be more worthwhile and beneficial to the patient if sufficient space can be created when crowding is present if you do not want to extract teeth. The IMPA is 92 degrees, the upper incisor to SN is 100 degrees, the A and B angle is 6.5 degrees. Again, I would not want to extract premolar teeth in this patient if possible. Along with the necessary maxillary expansion to correct the posterior crossbite, more comprehensive early treatment created sufficient space for Molly's crowded teeth. This is another case where appliances were removed for 4.5 months to wait for the eruption of the lateral incisor teeth. After the expansion phase of treatment, the posterior crossbite has been corrected and the functional shift of the mandible has been eliminated. The lower midline is centered and the class 2 occlusion on the left side has improved. There is adequate space for the eruption of the permanent teeth. 4 years after the completion of phase 1 expansion treatment, Molly started phase 2 treatment. The posterior crossbite correction remains stable. There is no functional mandibular shift and there is actually spacing in both the upper and lower arches. The lower facial profile is straight and pogonion has become more prominent. The incisor root structure is good. This is Molly's completed treatment. Total treatment time in fixed appliances for phase 1 and phase 2 was approximately 25 months. The A and B angle decreased from 6.5 degrees to 1 degree. IMPA increased from 92 degrees to 94 degrees after phase 1. At the completion of phase 2, IMPA was 90 degrees. The upper incisor to SN slightly improved from 100 degrees to 101 degrees. The lower incisor teeth actually uprighted in this treatment. This is a summary of Molly's cephalometric measurements. Molly's maxilla became more recessive with growth, widths worsened from +2, and lower facial profile continued to flatten, and the nasolabial angle became more obtuse. Maxillary extraction certainly would have exacerbated these changes. There was a significant decrease in the A and B angle from 6.5 degrees to 1 degree due to the lack of maxillary growth. SNA decreased from 80 degrees to 76 degrees, and as mentioned, the lower incisor teeth actually uprighted from 92 degrees to 90 degrees. This is Jackson. Jackson illustrates a situation where choosing the best treatment is more difficult and less straightforward. Jackson is severely crowded but also has a class 2 occlusion which will require more patient cooperation to correct if teeth are not extracted. This is something that is, of course, discussed with the patient when explaining treatment choices. Jackson was treated before the use of temporary anchorage devices, so a headgear appliance after expansion was planned as part of treatment. Today, I am sure very few orthodontists recommend headgear treatment. However, before the use of temporary anchorage devices, headgear treatment, when properly worn, could be an effective way to correct a class 2 molar relationship when the molar teeth needed to be distalized. There actually will be other cases in this presentation where headgear was used after expansion to obtain a class 1 molar occlusion and create additional space for the crowded teeth. Jackson is severely crowded with completely blocked out upper lateral incisor teeth and a lower left cuspid tooth. There is an end-on class 2 occlusion with a significant lower midline deviation to the left and an upper midline deviation to the right. We see on the panorex that the erupting upper lateral incisor teeth are resorbing the roots of the primary cuspid teeth. This is definitely a situation when teeth can be extracted for treatment. However, the maxilla is not protrusive and the upper incisor teeth are at 95 degrees to selenasion. The lower incisor teeth appear to be compensating for a slightly recessive mandible with an IMPA of 97 degrees. If premolar teeth were extracted in this treatment, the lower right cuspid tooth would have to be retracted sufficiently to correct the lower midline, and the upper cuspid teeth would be retracted a corresponding amount to maintain proper occlusion. This would not enhance an SNA of 80 degrees and an upper incisor to SN of 95 degrees. Jackson agreed to wear headgear and was treated with early expansion. At the completion of the expansion phase of treatment, there was still insufficient space for the upper cuspid teeth. Distalizing the upper molar teeth was necessary to gain additional space. Headgear was planned towards the late mixed dentition prior to starting phase 2 treatment. This is Jackson when headgear treatment was started. Headgear was planned for 9 to 12 months prior to placing fixed appliances. After headgear treatment, Jackson's parents were undecided on phase 2 treatment, and retaining appliances were not worn for approximately 18 months. Headgear treatment did improve the buccal occlusion and create more space for the upper cuspid teeth. This is 4 years, 8 months after phase 1 expansion was completed, 18 months without retention. The lower lingual arch wire was removed, anticipating Jackson would be starting phase 2 treatment. Some crowding redeveloped, but did not modify the intended treatment. Not properly wearing and retaining appliances after the first phase of 2-phase treatment can of course give rise to minor tooth movement similar to any orthodontic treatment. This is Jackson's completed treatment. The teeth are not fully occluded in the post-treatment frontal photo, so the tooth apart photo was included to show the level transverse plane. Unfortunately, the frontal photo was not retaken when Jackson returned for his retainer checks. The finishing phase of treatment after headgear took 9.5 months. Again, Invisalign treatment could have been a good alternative to fixed appliance treatment. Jackson finished with a very satisfactory facial profile with improvement in the upper incisor position and modest changes in the lower incisor position. Lower incisor to APO increased 1 millimeter. Lower incisor to NB increased 2.5 millimeters. And lower incisor to NB's angular relationship was essentially unchanged. IMPA increased 4 degrees. The mandibular recessiveness did not improve. A and B changed from 4 degrees to 5 degrees. This is a summary of Jackson's cephalometric measurements. The lack of favorable mandibular growth would have made the demands on extraction treatment much more challenging. The upper incisor to SN improved from 95 degrees to 100 degrees. Would this improvement have been possible if premolar teeth had been extracted? This is Caitlin. Caitlin is 10 years old and is delayed in her dental development. This is a late age for expansion. However, the mandibular cuspid teeth are still unerupted. Caitlin has a Class 2 Division 2 tendency with a deep overbite and is crowded with narrowed upper and lower arch forms. Also, the upper unerupted cuspid teeth and premolar teeth are ectopic. Unfortunately, Caitlin's initial panorex is not available. After Caitlin's phase 1 treatment, you can see the erupting maxillary first premolar teeth appear abnormal. Due to starting treatment at a later age, multiple primary teeth were lost during the phase 1 treatment. Losing primary teeth can make treatment more difficult and can sometimes lengthen treatment. Sufficient space, however, has been created for the permanent teeth. Approximately 1 year later, the maxillary cuspid teeth are now erupting. The maxillary right cuspid tooth remained ectopic, but the left cuspid tooth erupted into correct position. Caitlin has good upper and lower dental arch forms without having expanded the permanent cuspid teeth and premolar teeth, and the deep overbite is much improved. However, the mandibular second molar teeth appear trapped and possibly obstructed by the molar bands on the first molar teeth. The lower third molar teeth are also impacting. The lingual arch wire needs to be removed and the third molar teeth need to be extracted. The upper appliances were placed and the upper arch wire was stepped down so the retained primary cuspid tooth could be removed when the third molar teeth were extracted and the space for the ectopic cuspid tooth could be maintained. The step-down bends provided stops to maintain the space for the erupting cuspid tooth. This is Caitlin's finished treatment. The lower second molar teeth are fully erupted and functional. Caitlin has a straight recessive facial appearance with an obtuse nasolabial angle. This is showing Caitlin's cephalometric changes. The mandible became more recessive with growth. A and B increased from 2 degrees to 4 degrees. The widths changed from -2 millimeters to a +3 millimeters. The upper incisor teeth were in good position at the end of treatment. Upper incisor to NA was +4 millimeters and upper incisor to SN was 105 degrees. The IMPA increased 1 degree from 98 degrees to 99 degrees. Extraction of premolar teeth certainly would not have been favorable to improving the skeletal relationship with an SNA of 78 degrees and an SNB of 74 degrees. This is a summary of Caitlin's cephalometric measurements. This is another Jessica. This treatment demonstrates the importance of clinical assessment and judgment taking precedent over cephalometric parameters when those parameters are not providing clear diagnostic guidance. Jessica is aged 7 years 9 months and has a Class 1 occlusion with severe lower crowding and narrowed upper and lower dental arch forms. Her lower right lateral incisor tooth is completely blocked out and her lower incisor teeth are significantly deviated into the space of the blocked out tooth. Assessing Jessica's facial profile and smile, I did not want to extract premolar teeth. However, SNA at 86.5 degrees and an SNB of 5.5 degrees and an upper incisor to SN at 105.5 degrees are indicative of a maxillary protrusion where expansion might exacerbate rather than improve these cephalometric values. Jessica's composed facial countenance and her visage when smiling did not exhibit an appearance of a protrusive maxillary arch implied in these numbers. Jessica also had a high mandibular plane angle and upright lower incisor teeth with an IMPA of 84.5 degrees. As I discussed previously, I will sometimes remove appliances to wait for the eruption of the lateral incisor teeth. Upper molar brackets are not removed, so replacing appliances is very easy when the lateral incisor teeth erupt. Also, a simple retaining appliance can be made when brackets are removed to maintain the arch expansion and the space created for the lateral incisor teeth. It was 18 months before the lateral incisor teeth erupted. This is highly unusual. Normally at this age you would not expect that much time for the lateral incisor teeth to erupt. By removing anterior brackets, the upper appliances up to this point were on for less than 6 months rather than 24 months. After the lateral incisor teeth erupted, fixed appliances were replaced for several months to align the incisor teeth. This was probably not necessary, but I try to finish Phase 1 treatments as best as I can because many of these patients will need minimal Phase 2 treatment. At this point, the upper first primary molar teeth are exfoliating. Jessica's dental eruption was delayed. This is Jessica, aged 12 years 9 months, 2.5 years after the completion of Phase 1 treatment. The mandibular right primary molar tooth is still present. Due to the retention of the primary molar tooth and the presence of the lingual arch holding appliance, the normal transitional mesial shift of the mandibular first molar teeth did not occur, resulting in a Class 2 terminal plane occlusion. This was also preventing the eruption of the lower right second molar tooth. At this appointment, the lingual arch space-maintaining appliance was removed, and Jessica was referred to have the primary molar tooth as well as her third molar teeth extracted. Headgear treatment was recommended to obtain a Class 1 occlusion before placing Phase 2 appliances while waiting for the eruption of the mandibular second premolar tooth. This is Jessica's Panorex taken before removing the lingual arch wire, showing that the mandibular right second primary molar tooth was not exfoliating and the mandibular right second molar tooth was crowded and unerupted. Also, you can see the mandibular third molar teeth were impacted. As mentioned, the lingual arch wire was removed and Jessica was referred for third molar extractions and the extraction of the mandibular right second primary molar tooth. 2 years later, treatment was completed. A large amount of that time was waiting for the eruption of the mandibular right premolar tooth. Jessica was not wearing full fixed appliances during the period of time she was wearing headgear and while waiting for the eruption of this tooth. In hindsight, ligating the premolar tooth when the primary molar tooth and the third molar teeth were extracted might have been a better choice. Even though the upper incisor to SN increased, Jessica's profile improved. Also, the lower incisor teeth were advanced and the lower lip became less protrusive. These are Jessica's cephalometric measurements. This is Grace. Grace is age 8 years 4 months and has a very narrow dental arch form with severe crowding. She has a deep overbite Class II Division II type malocclusion, and there is advanced gingival recession on the mandibular left central incisor tooth. Grace has a straight lower facial profile with upright maxillary incisor teeth. The upper incisor to SN is 88.5 degrees. The lower arch form is extremely narrowed with severe incisor crowding. With an A and B of 5.5 degrees and an SNA of 78 degrees with upright maxillary incisor teeth, I thought it would be best not to extract premolar teeth if possible. A screw-type lower expander was used in Grace's treatment. As I mentioned previously, this appliance is normally used when the permanent first molar teeth are insufficiently erupted and cannot be banded. The expander is placed on the second primary molar teeth. This appliance can be used instead of the W expander for expanding the lower arch if one prefers. However, the W expander is more flexible than the screw-type appliance and can be adjusted to expand the primary cuspid teeth without expanding the molar teeth. Also, molar teeth can sometimes be rotated if necessary and uprighted and tilted lingually with the W expander. This slide is showing the progression of upper and lower arch expansion using the screw-type expander. This is Grace at age 9 years 4 months after her initial phase of expansion treatment. The gingival recession on the mandibular left central incisor tooth does not appear to have worsened and appears to essentially remain unchanged. 3 years 2 months after the completion of Phase 1 treatment, Grace is ready to start Phase 2 treatment. The lower lingual arch wire was removed sometime earlier, possibly to allow for second molar eruption, and some lower incisor irregularity developed. Also of significance, the gingival recession on the lower incisor tooth has not worsened. And this is Grace's lower facial profile and her x-rays prior to starting Phase 2 treatment. Grace's Phase 2 treatment was completed in 11 months. As you can see, the gingival recession on the mandibular left central incisor tooth did not worsen during treatment. Incisor teeth were advanced during treatment, but did not cause any worsening of the gingival recession that was present prior to starting treatment. The IMPA increased 8 degrees, which is equivalent to approximately 2.6 millimeters of incisor inclination, which was partially due to the use of Class II elastics during the second phase of treatment. The upper incisor position was much improved from an upper incisor to SN of 88.5 degrees to an upper incisor to SN of 102.5 degrees. With the upper incisor teeth at 88.5 degrees at the start of treatment, increasing the lower incisor angulation 8 degrees most likely produced a more favorable aesthetic result than if 4 premolar teeth had been extracted. These are Grace's before and after pictures showing that the gingival recession did not worsen with expansion treatment and the increased IMPA angle. The following slides show more examples of advanced gingival recession that was present prior to treatment but did not worsen with expansion treatment. This is another example demonstrating gingival recession not worsening with expansion treatment. Again, another patient with gingival recession caused by an anterior crossbite which did not worsen with expansion treatment. These are examples of early gingival recession, which has not progressed beyond the cemento-enamel junction, but would be considered susceptible to worsening from orthodontic treatment. These examples seem to be consistent with studies that have found that there is not a correlation between proclining incisor teeth and gingival recession. This is Emma. At her initial visit, Emma presented with not only severe anterior crowding, but posterior crowding as well. The maxillary first molar teeth were ectopic and possibly trapped by the second primary molar teeth. The upper permanent incisor teeth had not yet erupted. Emma was placed on a 6-month recall to reevaluate. In 6 months, the maxillary incisor teeth had erupted and the crowded molar teeth had improved and erupted into occlusion. Emma is severely crowded. The arch forms are narrowed and the teeth are of normal size. The mandibular incisor teeth appear retro-inclined in the photos and the maxillary incisor teeth appear upright as well. The cephalometric analysis confirms the clinical assessment of upright incisor teeth. Upper incisor to SN is 89 degrees and the IMPA is 83 degrees. Emma has an A and B angle of 4.5 degrees and a high mandibular plane angle of 44.5 degrees. The upright incisor position and the narrow dental arch form were decisive in choosing expansion treatment over extraction treatment. At the completion of Phase 1 treatment, sufficient space for Emma's permanent teeth was created. This was attributed in a large part to advancing the incisor teeth. The upper incisor teeth were advanced approximately 10 degrees, or approximately 3 millimeters if uncontrolled tipping occurred, and the lower teeth were advanced approximately 8 degrees, which would be approximately 2.4 millimeters of uncontrolled tipping. Approximately 2.5 years after Phase 1 treatment was completed, the permanent teeth have erupted with a Class II occlusion on the left side and insufficient space for the maxillary left cuspid tooth. The lower arch also appears slightly asymmetric. The mandibular left cuspid tooth appears slightly more distal than the mandibular right cuspid tooth, with the lower dental midline skewed to Emma's left side. A headgear appliance was started at this time. I believe the maxillary left cuspid tooth eventually was surgically ligated when appliances were placed. This is Emma's finished treatment. I was not able to fully correct the lower arch asymmetry. The Class II relationship on the left side is slightly undertreated. Also concerning is the gingival recession on the cuspid teeth, which could be related to the cuspid expansion during Phase 2 treatment, but also might be related to Emma's high mandibular plane angle and vertical growth pattern, which can also cause this to occur. Emma's A and B worsened from 4.5 degrees to 7 degrees with growth and/or treatment. The IMPA increased from 80 degrees to 94.5 degrees to compensate for the recessive mandible and increased mandibular plane angle. The upper incisor to SN actually decreased 1.5 degrees. The upper incisor to SN started at 89 degrees, improved to 99.5 degrees, and finished at 87.5 degrees. When assessing Emma's facial changes and her pleasing smile, I believe not removing teeth was a good choice for Emma. If the upper incisor teeth uprighted more after non-extraction treatment, they most likely would have uprighted even more with extraction treatment, increasing the chance of an unfavorable aesthetic result. This is Megan. Megan is not a severe or moderately crowded patient, but I included her to demonstrate that a bonded rapid palatal expander can be effectively used in treating open bite malocclusions. My experience, which is purely anecdotal evidence, is that using bonded appliances with acrylic covering the occlusal surfaces of the teeth in young patients is generally very effective in reducing an anterior open bite. This was also demonstrated previously to a lesser extent in Molly's treatment, patient number 4, and will also be demonstrated in the next patient who has an open bite with crowding. Megan was simply treated with a bonded expander, no other appliances, to expand the constricted maxillary arch before deciding on additional treatment. After the bonded expander was removed, the open bite had closed, but as the dentition continued to develop there was insufficient space for the eruption of the maxillary cuspid teeth. Since the maxillary incisor teeth needed to be advanced to maintain a normal overjet relationship, and there would be additional leeway space when the second primary molar teeth exfoliated, the maxillary first premolar teeth were not extracted to allow the blocked-out cuspid teeth to erupt. Because of the initial open bite occlusion, headgear was cautiously started prior to placing full appliances to create more space and to establish a good Class 1 molar relationship. This is Megan after wearing a headgear appliance for 6 months prior to placing fixed appliances. The open bite has remained closed and there is sufficient space for the previously blocked out cuspid teeth. This is the progression of cephalometric changes that took place through the course of Megan's treatment. After expansion with the bonded RPE, the upper incisor teeth uprighted and needed to be advanced as part of the second phase of treatment. The upper incisor to SN started at 105 degrees, uprighted to 92.5 degrees, and finished at 99 degrees. The lower incisor teeth basically remained unchanged throughout treatment. The mandibular plane angle decreased slightly after wearing the expansion appliance, but at the completion of treatment was close to the initial measurements. This is Megan's completed treatment. The open bite correction remained stable with a very aesthetic lip line. No vertical elastics were necessary, attenuating the risk of producing undesirable excessive gingival exposure. This is Taylor. Taylor is another example of an open bite treatment but with severe crowding. Taylor had severe anterior crowding as well as crowding of the erupting maxillary first molar teeth. At this appointment, it was recommended to have the maxillary and mandibular primary cuspid teeth extracted. Expansion treatment was not planned at this time. I included Taylor because she is an example of a patient who on initial examination would not be considered a good early expansion patient. When Taylor was seen again 9 months after her initial visit, the primary cuspid teeth had not been extracted and the mandibular left second primary molar tooth had been lost. I believe it had been extracted. The mandibular right lateral incisor tooth erupted labial to the primary cuspid tooth, which was still present, and the maxillary first molar teeth erupted unobstructed. Taylor's open bite improved with the continued eruption of the maxillary incisor teeth, but still persisted. Taylor's Panorex revealed that the maxillary right and left primary cuspid teeth were exfoliating from resorption caused by the erupting lateral incisor teeth, and the mandibular right primary cuspid tooth had no root structure and was also close to exfoliating. The previously problematic maxillary first molar teeth fully erupted, and the blocked-out mandibular right lateral incisor tooth erupted labial to the very mobile primary cuspid tooth. The upright maxillary incisor teeth were in an edge-to-edge overjet relationship with an upper incisor to SN of 95 degrees. The crowded mandibular right lateral incisor tooth erupted without needing to extract teeth or expand the very narrowed mandibular intercanine arch width with an IMPA of 94 degrees. As a result, extracting the primary cuspid teeth was no longer necessary. Expansion treatment was guardedly decided on to try and avoid extraction of permanent teeth. At the completion of the first phase of treatment, sufficient space was created for the permanent teeth, and the deviated lower midline was centered. After the initial phase of treatment, the lower incisor teeth were advanced more than desired, and the lower second molar eruption appeared to be obstructed by the bands on the first molar teeth. For these reasons, the mandibular lingual arch wire was removed at this time. This is Taylor prior to starting phase 2 treatment. After the lower lingual arch wire was removed, the lower incisor inclination improved. However, the second molar eruption was still delayed. Taylor did not wear her upper retainer, so some irregularity developed. There is also still an open bite tendency. This is Taylor's completed treatment. The second molar teeth in this treatment were not banded because of the concern of redeveloping the initial open bite occlusion. These teeth were delayed in eruption, and because of concerns with dental hygiene and enamel decalcification, not prolonging treatment with the risk of redeveloping an open bite was not the ideal choice, but I believe the prudent choice in this circumstance. In reviewing Taylor's cephalometric changes, we see that the upper incisor to SN improved from 95 degrees to 103 degrees. The IMPA increased from 94 degrees to 100 degrees. The lower incisor to the APO line remained unchanged at plus 2 millimeters, and the lower incisor to NB remained unchanged at plus 5 millimeters. The position of the upper incisor teeth improved with a very aesthetic result. The lower incisor teeth, which initially were more labial than desired for expansion treatment, were proclined 6 degrees, which would be approximately 2 to 2.5 millimeters of tipping, but were not significantly changed in relation to the APO line and the NB line. The third molar teeth need to be extracted. As you may have noticed, in most of the patients in this presentation, the third molar teeth have not been extracted. The post-treatment radiographs are taken the same day appliances are removed, and usually I do not refer patients for third molar extractions until after their orthodontic treatment is finished, unless there is a need to extract them sooner. Even though this is not primarily related to treating crowding, I wanted to show how early expansion treatment is used for Class 3 treatment. Early Class 3 expansion treatment with protraction headgear is commonly used and can be effective in certain Class 3 malocclusions and anterior crossbite corrections. Oftentimes, patients with Class 3 malocclusions will have significant crowding of the maxillary arch, but little or no crowding in the mandibular arch. Assessing whether early Class 3 treatment is beneficial requires consideration of many things. However, alleviating crowding to avoid maxillary extractions in the future and correcting traumatic anterior crossbites are indications for early treatment, even if there are limitations to correcting the Class 3 malocclusion. Traumatic anterior crossbite can have severe dental health implications if left untreated. Anterior crossbite may lead to abnormal enamel abrasion of the maxillary and mandibular incisor teeth and dental compensation of the mandibular incisor teeth, leading to labial alveolar bone loss and irreversible gingival recession. Traumatic anterior crossbite requires early and immediate treatment to prevent harmful things like tooth mobility and fracture, periodontal pathology, and temporomandibular joint dysfunction. Phase 2 Class 3 orthodontic treatment can have limitations and often requires orthognathic surgery, which is a treatment option many patients choose not to consider. However, there are early Class 3 treatments which have good outcomes and remain stable as a patient continues to grow. Phase 1 Class 3 treatment requires rapid maxillary expansion in conjunction with protraction headgear to move the maxilla forward. Mandibular expansion may or may not be necessary, but fixed appliances are sometimes necessary without expansion for the use of Class 3 elastics or springs. This is a type of bonded rapid palatal expander with protraction headgear hooks. You can see the bite opening effect of the acrylic covering the teeth, eliminating any occlusal interference to correcting the anterior crossbite. This type of face mask protraction headgear is usually well tolerated and easy to wear. The main problem with this type of appliance is the skin irritation caused by the chin cup, which can be severe. Moleskin is routinely provided to line the chin cup, which can reduce the irritation. A lower W expander was used in this treatment to maintain the upper and lower transverse relationships since there was not a posterior crossbite when treatment was started. Because of the bite opening effect of the expansion appliance, the anterior crossbite was easily corrected and allows for early placement of lower appliances. The lower extension wires on the W expander are bonded to the primary cuspid teeth, creating abutments so a sectional arch wire can be effectively used. The lower W expander was overexpanded. However, overexpansion is better than underexpansion if it is not excessive. In this slide, the RPE appliance has been removed and the extension wires on the W expander have been removed. The lower lingual portion of the W expander is retained to stabilize the molar teeth. A lower utility arch wire has been placed. This is the completion of Phase 1 treatment. Treatment time was 10 months. The traumatic anterior crossbite has been corrected. Also note how the lower primary cuspid teeth recovered from the initial overexpansion from overactivating the W expander. I do want to show one treated Class 3 patient with significant maxillary crowding. Early protraction headgear treatment is most effective when there is a deficient maxilla with an overclosed mandible and deep overbite. In this type of circumstance, because of the anterior crossbite, the mandible can sometimes be functionally displaced anteriorly, making the mandible more prognathic, which is not a true skeletal discrepancy, but a functional mandibular protrusion. This is Jamie. Jamie has a Class 3 malocclusion with a complete, potentially damaging anterior crossbite, a narrowed maxillary arch form with a posterior crossbite on the left side, and significant maxillary crowding, with the maxillary right lateral incisor tooth completely blocked out. Jamie definitely has a skeletal Class 3 relationship. Her A and B is a minus 4.5 degrees, and her width analysis is a minus 5 millimeters. Her SNA of 75 degrees suggests a retrusive maxilla, and her SNB of 79.5 degrees suggests a normal mandible. At the completion of Phase 1 treatment with protraction headgear, the anterior and posterior crossbites have been corrected and the traumatic incisor relationship eliminated. There is adequate space for the eruption of the permanent teeth. 3 years after the completion of the first phase of treatment, the crossbite corrections are stable. Starting the second phase of treatment in Class 3 patients can be problematic in patients who are still growing. Jamie was 14 years old when she was ready for Phase 2 treatment. Her occlusion appeared stable for 3 years. If there were indications that the Class 3 malocclusion was worsening, it would be best to wait on the completion of facial growth before starting additional treatment. This is Jamie at the completion of treatment. At the end of treatment, Jamie's SNA improved from 75 degrees to 80.5 degrees. SNB unfavorably increased as well from 79.5 degrees to 84.5 degrees. The A and B slightly improved to minus 4 degrees, and the width analysis improved slightly from minus 5 millimeters to minus 3 millimeters. Jamie's facial profile improves with treatment. In the pretreatment ceph, the mandible appears overclosed vertically, but the mandibular plane angle decreases with treatment, contrary to what one would expect. A and B changes very little from minus 4.5 degrees to 4 degrees, and the width analysis slightly improves from minus 5 degrees to 3 degrees. The lower facial height improved, but it does not appear to be due to clockwise mandibular rotation. Jamie's cephalometric analysis at the start of treatment suggests that the Class 3 malocclusion is due to a deficient maxilla with an SNA of 75 degrees, 7 degrees less than the norm of 82 degrees. The mandible appears normal with an SNB of 79.5 degrees, very close to the norm of 80 degrees. After treatment, however, the SNB increases 5 degrees from unfavorable Class 3 growth, indicative of a more prognathic mandible. SNA improves 5.5 degrees to 80.5 degrees, closer to the norm of 82 degrees, which most likely is attributed to wearing the protraction headgear. With normal growth, the SNA would stay about the same, and in patients with maxillary deficiency, sometimes worsen. You would not expect an increase in the SNA of 5.5 degrees with routine growth. Because of the unfavorable growth of the mandible, the maxillary incisor teeth had to be excessively tipped forward to compensate for the 5-degree increase in the SNB. With normal mandibular growth, the improvement in the SNA of 5.5 degrees from the protraction headgear treatment would have improved the Class 3 skeletal relationship, and the incisor teeth would not have been tipped as much to compensate for the A and B difference. Even though the maxillary incisor teeth were excessively tipped forward, I think this is an acceptable orthodontic solution to correcting the Class 3 malocclusion without orthognathic surgery. Early maxillary expansion with protraction headgear treatment made this possible. Had there been normal rather than Class 3 mandibular growth, the outcome, of course, would have been better. Had there been no early treatment, orthognathic surgery may have been unavoidable. Today, with the use of temporary anchorage devices, the mandibular teeth might have been retracted more, reducing the need to excessively tip the maxillary incisor teeth. In summary, I hope this presentation increases the awareness that young patients with significant crowding can be successfully treated in a conscientious and prudent way without extracting teeth, and without disregarding the parameters of good orthodontic treatment and standards of care. Of course, not every crowded young patient is best treated with early expansion, but early expansion can be an appropriate and valuable treatment option in the right circumstance to broaden the scope of things we can do to treat major crowding beyond simply extracting teeth. Orthodontists are responsible for making treatment decisions in very young patients that can either favorably or unfavorably affect future dental and facial growth and development. Recognizing that there are treatments that can favorably enhance a patient's treatment outcome when it is felt that the extraction of teeth might have an adverse effect on that outcome is something I hope you acquired from this presentation. Importantly, I hope you took notice of the dentitions after the first phase of expansion treatment, after all the permanent teeth had erupted. These dentitions are well within acceptable parameters of good orthodontic treatment. These are dentitions that can routinely be treated without extracting teeth, and in some cases only require minimal additional treatment. As I mentioned, Invisalign treatment could very well be used as a second phase of treatment instead of fixed appliances for some of these patients. On the other hand, the adult dentitions that potentially would have developed without early intervention would most likely present potential periodontal complications or potentially require adjunctive periodontal surgery and bone augmentation if expanded and treated without extraction of teeth. Since early expansion is done before the eruption of the permanent cuspid teeth and premolar teeth, the most significant dental arch modification to increase arch length after the permanent teeth have erupted is the advancement of the incisor teeth. Is the choice to advance incisor teeth a better option than extracting 4 premolar teeth? That really is the fundamental choice. The question is, how much advancement is acceptable? This is the question that needs more research to quantify. Also, we need to determine how significant bone loss caused by treatment is over the long term, and how does it compare to people who never have orthodontic treatment. Finally, I would like to say that my decision on whether or not teeth should be extracted in very young patients is primarily based on my subjective aesthetic assessment of the patient. Do the teeth appear too protrusive or too procumbent? Does the patient have too much lip strain when closing their lips together? Or will these things worsen if teeth are not extracted? In a young child, the amount of crowding is generally not what dictates whether or not I choose to extract teeth. I did not use any type of arch length analyses to quantify the amount of crowding in the patient shown in this presentation. That is because arch length analyses are more relevant when diagnosis is constrained by arch length parameters that cannot be changed and when restrictive cephalometric means are established as treatment goals. Arch length analyses that include cephalometric corrections and leveling of the curvus B corrections lead to very large arch length deficiencies to rationalize the extraction of teeth. It is important that we pay attention to the limitations of our treatments, but traditional treatment parameters apply to permanent dentitions and not to early developing and changing dentitions. Mixed dentition arch length analyses need to take into consideration normal growth changes which significantly affect how crowded a patient will be. I think that the severity of the crowding in the patient shown in this presentation was obvious without being precisely quantified. A particular amount of arch length deficiency does not dictate when you should extract teeth or when you should wait and observe a patient or when you should consider expansion treatment. I will finish by saying that your best guide to treatment is to not apply double standard when you make your treatment decisions. Do for your patients what you would want done for yourself. If you feel not extracting teeth will give the best outcome, hopefully now you will be more comfortable considering alternative treatment. Thank you for your interest and attention and for taking the time to listen to my ideas and thoughts on how we can approach treating crowding in our young patients in a proactive way without always resorting to extracting teeth. I want to acknowledge a person who was extremely helpful for many years, keeping track of and copying over 150 patient records so they were available to me to document the early expansion treatments in my practice. I first met Laura as a patient when she was about 7 years old. Because Laura was the best headgear wearer I had ever had in my practice, I eagerly hired her 9 years later to help in the office as part of an after-school job program she was participating in at her school. Laura did not ever leave. She continued to work in the office while she was in college, and then despite opportunities her college education afforded her, chose to carry on working with me for 25 plus years until I retired. Laura is still currently an enthusiastic and valuable staff member to that practice. I want to thank Laura for helping me and for her hard work and dedication. Because of all her hard work, I felt compelled to put together this presentation, and I hope it will be of some benefit to those who have an opportunity to view these treatments.